Welcome back, everybody. Amanda and I have just been talking about the chats that have come in, where someone asked, how do we tell the difference between bulbar conj and lid conj? So it is about what's underneath. So the bulbar conj is often quite flat. It has more, I think it has more numerous goblet cells actually. And has very delicate stroma underneath it, and the stroma is extremely thin. Whereas if you get tarsal conj, it will definitely have some other stuff underneath, like glands. And it's just observing what's in the stroma, I think, that will tell us the difference. There was a question about pyogenic granuloma versus granulation tissue. Pathologists don't use the term pyogenic granuloma anymore. We call them lobular capillary hemangiomas, emphasizing their tumor-like thing. I would say a pyogenic granuloma is a benign tumor-like lesion. It has a feeder vessel and lobules of proliferating vessels and has to be purposefully treated. It is something that grows out of control, whereas I want to say out of control, grows in a benign fashion, whereas granulation tissue is a physiologic response that organizes over time to form a scar. They're similar in that they have small vessels in them. They're different in that the physiology behind them is different. One matures normally and the other one doesn't. I'm just going to share my screen here. I popped into DermNet. Here it's showing this pyogenic granuloma. So macroscopically, they're quite different. The pyogenic granuloma is a raised nodule, whereas granulation tissue is usually part of a healing scar. Okay, here we go. And they're also treated quite differently, because you would never ever treat granulation tissue like this by surgical excision. Usually it's part of a healing response to surgical excision.
You just get more granulation tissue.
That's right. You wouldn't cryotherapy it or use imiquimod. So these treatments emphasize the difference that the previously called pyogenic granuloma and now lobular capillary hemangioma is really a benign tumor.
So on the conj, if you call it a pyogenic granuloma, well, if they look like the same as in the skin, I should expect. Do we get lobular capillary?
You can get pyogenic granulomas on the conj because they have to be treated, don't they? They're not some clinicians put the ones post-strab surgery, I guess.
Yeah.
So the difference between an exuberant healing response and which is granulation tissue, and a pyogenic granuloma, I think depends on its natural history. So an exuberant healing response will, in time, hopefully calm down, whereas if it continues to grow and forms a nodule, we're going to call that a lobular capillary hemangioma, particularly if it's got a feeding vessel and we see these lobules of proliferating vessels down the microscope. Okay, we are running long here. I did kind of expect this because I put in a ton of slides because I knew that this was an area that people needed to concentrate on. So please forgive us as we carry on. Are you all okay with just carrying on? Yep. I think that what we're going to do next is move on to the next slide. So conjunctive, here we go. So we're now on slide 5, which is that papillary looking lesion. And I will again put us in random breakout rooms. Off we go. Opening your rooms. Excellent. I'm going to start the recording again. I'm going to definitely resume the recording again. There we go. I must have pressed it twice. Okay, so everyone's been looking at the slide from the number 5 there. Are you going to do that, Amanda, or am I going to do that?
I don't mind.
As well, did you want to run through quickly slide 4A?
Oh, okay. I just put that in. Can do. How do you want to do that?
I just think it would be nice to show them,
Sure.
like
Okay.
the features quickly. The features of a sebaceous carcinoma.
Okay, I'll do that one. I'll go down. Just found this in my collection. So we were talking about why is a chalazion or lipogranulomatous inflammation not a sebaceous carcinoma? Good to know the difference. Right. Here is an example of not a chalazion, but you can see the tissue is actually very similar. So it looks like to me we've got skin with adnexal skin hair follicles on one side. We've got lid margin. We're coming around to the conjunctival surface. We've got the tarsal plate with the meibomium glands in here. What we particularly want to look at is the thickening of the surface here in the at the lid margin. There's other things going on, but we just want to focus on this. And why is it thickened? Okay, at this power, it could be because of squamous cell carcinoma in situ, squamous dysplasia, or something else. And what I notice immediately is besides being thickened, it has got a lot of clear cell change. Clear cell change can be glycogen or it can be lipid. So when that renders, maybe I should just go to the small screen. I'll just go, oh, it's coming now. That's good. And this is what we were talking about, intracytoplasmic lipid rather than extravasated lipid with a granulomatous response. All of this here is a neoplastic growth. And see these cells here, they've got the intracytoplasmic lipid, little clear spaces inside, kind of like a meibomium gland, except for it's not. So,
I quite like this slide because it's also got a little granuloma down the bottom.
yes, I was trying not to confuse people with that, and I zoomed straight into this. So here you can see the lipids inside the neoplastic cells themselves. So this is a sebaceous carcinoma.
Yeah.
And way over here, there's some, I think, some granulation, but this is the bit we want you to focus on. So I'll stop.
Yeah, so that I think the little granuloma, yes. I don't know, it looked like it had a bit of foreign body in it to me, a bit of suture material.
Maybe somebody's been in there before and this is a re-excision. So
yeah.
It's possible. Like, yeah, that looks like reactive to me. That's a neoplastic.
Yeah.
And yeah, you see there's more clear up here. You see how you can spot it all at low power and then you know where to look.
Yeah.
Anyway, enough of that.
Okay. All right, so back to the papilloma.
Where am I? All right, do you want to do that one, Diane, then?
Sure, I will share screen.
I've lost my thing. I'll do chat.
Here we go. I've got too many little things open. Here we go.
Yeah,
I'll have to tidy them up in a minute. Okay, now I'll share screen. All right, so at low power here, we've got normal stuff down the bottom here, and we've got a lesion here. Right? And here at the normal, we can see goblet cells in it here and no skin adnexy, so we know we're in the conj. We can't see any underlying like stromal glands or anything. And there's numerous goblet cells, so I suspect them in the bulbar conj.
So Diane, did you think this was sun damaged or not? Like there were lots of...
Yeah. So there's some curly sun damage through here. I think we're definitely.
How do we tell the difference between sun damage and normal collagen? Because we all
so normal collagen is fine and kind of fluffy, and sun damaged collagen goes wiggly and thick, and it often has a purple tincture to it. Though the slides are so variably stained, it may or may not have a purple tincture to it. But on the nice new fresh ones that Amanda and I get to look at, it has a purple tincture. And then at low power, it's got these finger-like projections. So you can imagine this is a finger in a glove, and this is the classic papilloma picture. So when we talk about a papillomatous architecture, we mean this. It's a finger in a glove. And probably this was just like snipped off at the base here, and this was the floaty papillomatous lesion. So the papillomatous growth has some residual conjunctival goblet cells in it, but most of it over here is squamous cells. Now, let's describe the squamous epithelium. It's non-keratinizing squamous epithelium. And the cells you can see stream up from the bottom. So they're all quite similar looking. In places, they do mature into cells that have little bridges between them, though we can't actually see it because the scan's not good enough. But as we look around, there's no mitoses, and all the cells have a kind of similar look to each other. There's no really big ones, there's no mitoses. They kind of stream up. So these are basal cells, but they are normal basal cells that are extra thick. So this papilloma is a benign papilloma. It doesn't show the mitotic, pleomorphic, dysplastic features of a papilloma that is neoplastic. But this expansion of the basal cells can be quite tricky because this hyperchromatism can also be a feature of neoplasia. So I think that we need to recognize that not all the features of neoplasia are present and that these are expanded basal cells. The other place we get expanded basal cells is the seborrheic keratosis. But similar to the seborrheic keratosis, this doesn't have mitoses or pleomorphism. These can be viral papillomas, and I looked around, but I couldn't actually see any coilocytes. I couldn't see any specific viral features. Could you see any, Amanda?
No, but we don't need to see them.
We don't need to see them.
We know that they're most often driven by HPVs anyway.
So this is a benign conjunctival papilloma. Do I have any questions that have come up?
So far, no questions. Go ahead and ask if you've got any. We saw lots of little dotty cells in amongst the squamous cells in some of those thicker parts. You could point those out and tell us what they're in there. What are those extra cells?
So those little cells, okay. So they're kind of the same as these little cells here. You can imagine the eyelid bashing this round a bit and it becoming very inflamed. And indeed it has. We've got all these inflammatory cells in the stroma and they've migrated into the overlying epithelium. So these are lymphocytes.
And maybe some neutrophils.
Yeah. Oh yeah, there's one. There's some newts. You're right. There's some newts there too.
So just inflammatory cells.
Inflammatory cells. Yeah.
Okay, good. No other questions.
No other questions. All right. So we've got a bit of a compare one next, haven't we?
I think so.
I'm going to stop sharing. I'm going to put recording. Great. Everyone's coming back. Did you have questions you wanted to ask?
No, we weren't quite sure why it wasn't like loop related. Like it wasn't like, I mean, it looks like there's this lobules of squamous cell.
All right. So you couldn't see the papillomatous structure? Is that what you're saying?
Yeah, I mean there is a structure, but is this papillomatous squamous cell carcinoma or what is? We don't know how to describe the overall
like a cauliflower.
It is like a cauliflower, isn't it?
I thought it looked like a cauliflower.
Oh, yeah.
I'm feeling hungry now. I was thinking, cauliflower cheese for lunch. That would be great.
I don't have any in the house. All right, whose turn is it?
I think it's your turn.
Okay.
Yeah.
All right, I will describe cauliflowers. I'm going to call it a cauliflower because I can. So there. All right. Am I sharing the right screen? I hope so.
Yeah.
Okay. It's two pieces of tissue. First of all, I want to establish where are we? What is the normal? So I can see there's some cauliflower-like proliferation down here. I think that's abnormal. I think this is some thickened something that's abnormal. I can see this is probably the normal stuff. I don't know, and maybe that's some normal stuff there. So I want to go and have a look at the normal area so I know where I am. So I can see this is squamous epithelium. I don't see any goblet cells. I don't see any skin adnexy either. I just see subepithelial stroma. I see epithelium,
Can
inflammatory
you see
cells.
wiggly collagen? Do you think it's?
Yes.
I think it's.
Yeah, and over here this is kind of bled into itself, so it's not so well defined. But over here, I can see sort of like bluer amphiphilic areas. More, where was it? It does have that sun damage look to me.
And what about all those big vessels, Amanda?
Yes, they seem to be very large, and I wouldn't expect those to be in skin. I actually think this is probably conjunctiva with squamous metaplasia. It's very inflamed, and it's got all these large vessels like you see in pterygia and sun-damaged conj. That's what I'm thinking. There's another little area I wanted to have a peek at. Oh, okay. This here is all streaming and squished because of thermal and or crush artifact. So that's when you've fried it and sent it to us. That's what it looks like. Makes it really hard to identify. But this blueness suggests to me also that there is solar elastosis and skin damage, solar damage. I think we're in conjunctiva of a sun-damaged person. Now I'm going to have a look at the lesion. So arising within the squamous conjunctiva, there is a squamous proliferation because they're still squamous cells. I can tell because I'm making squamous whorls. See the whorls there? Squamous differentiation. And this cauliflower type lesion down here, architecture first. This looks to me like a cauliflower type lesion because I can see lobules that are coming off a central stem or a core. So there's the core of the cauliflower and these are the florets. So this is also a type of papillomatous picture is what I can see here. Maybe the fingers aren't so long, but it's more cauliflower, but a cauliflower is the same type of architectural arrangement. I don't think this is a solid nodule. It's not craterform, it's not ulcerated. I think this is papillary architecture. And what's it look like more closely? I can see squamous for the features described previously, but unlike the squamous papilloma, I certainly see a lack of normal maturation from basal to surface. The cells are very large and there's pleomorphism in size and shape between them. And there's also the spatial arrangement, instead of being very close together and then getting further apart as they move upwards in a normal maturation pattern, they are like crowded together and then they are very far apart, crowded and very far apart. So it's sort of like a riot rather than an orderly maturation. So I think there is dysplasia in here, and the dysplasia goes from the basal layer to the surface layer. Just seeing if this exists all the way around, and I see the same pattern everywhere I look. I'm looking for mitotic figures. Here's a mitotic figure, here's another mitotic figure, and they're about halfway up. So I think this is a high-grade squamous dysplasia. Is it in situ or is it invasive is the next question. So I can see good epithelial stromal interface. I can draw my pencil around the lines here. I don't see invasive infiltrating fingers and I don't see a stromal reaction. I'm just going to have a look at this other bit over here. Here it's a bit obscured because of inflammation, but I can see it's growing up rather than down, and it's got the same dysplastic process. So I think this is, from what I can see, it looks like a conjunctival squamous intraepithelial neoplasia. I would grade this as severe, or SCC in situ, or CIN3, or whatever you'd like to call it. I can't actually see invasion. It's quite a superficial biopsy as well. Questions, Diane? What can we elaborate on?
No, I think that was a good description, and I like these two because it shows quite clearly the difference between benign and malignant cells, which is something that I think their candidates have to be able to recognize really well on the small biopsies.
And the clue is there's often the patient's own benign cells. And then you look over here. Oh my goodness, what's happened? This is orderly and this is a riot. Orderly, riot. That's how you can tell the difference.
All right, let's move right along, I think, to the next slide here, which again, we're still in the conj.
Where are we?
I'll put everyone in a slightly different breakout room this time.
Oh, Chris has just got a question.
Oh, Chris,
So
yeah.
You call it, oops, I've lost the question.
Yes, you'd call it SCC in situ, but with a papillomatous morphology, the answer is yes.
Yes.
Yeah, yeah. Good, off we go. Oh, 2 breakout rooms. Oh. 5 breakout, 6 breakout rooms. Recreate, off we go. Right, hopefully you'll be able to join just now. Recording again. Okay, so how was that?
I think it was good. It has this homogeneous pink appearance, which gave it away, I think.
I saw everyone now confidently finding that it was in fact conjunctiva overlying the eosinophilic mass there. Okay, we're just getting everyone back. Okay. I'm going to share the screen.
Oh, it's exactly what we were discussing. How do you identify it?
Okay, so I think everyone got this as I went around the room. So everyone spotted the lovely goblet cells on the surface. So this is conjunctiva, and then underneath we have got this eosinophilic acellular mass that is absolutely characteristic of amyloid. We discussed why it wasn't calcium, and that's because it's not dark purple enough. We discussed in some places why it wasn't dense fibrosis, and that's because These blobs are acellular, and fibrosis has collagen nuclei in it. And it's also much more linear. So this is pretty much a spot amyloid diagnosis. And then as we came up, everyone would have then proposed that the right stain to do was the, please chorus.
Congo red.
Congo red, right. And then I popped up this nice stain for Congo red. This is from a kidney, actually. So without polarizing, these gloms look pink, and with polarizing, we get the apple green birefringence. Now, collagen also birefringes normally, but it's a white birefringence. And this apple green birefringence will tell you that it is amyloid. Now, extra for experts, what are the main kinds of amyloid? Stop share. So amyloid can derive from.
Okay, you can type in the box so we can call it out.
Light chains.
Are we talking about primary and secondary amyloid?
Yep.
Yeah, so it could be a part of systemic or localized amyloidosis. Systemic could be like lighter chain amyloidosis from like myeloma, or it could be from chronic inflammation like amino acid amyloidosis.
Great. So that's good. I love your framework. There's localized and systemic, and then there's light chain versus non-light chain or proteinaceous amyloid. How could we tell the difference between those two types, do you think?
I don't know. I'm not quite sure. I think by.
If it's full of light chains, do you think it's going to be a clonal light chain it's full of?
I would assume so, yeah.
So our first stop might be kappa or lambda staining with immunohistochemistry.
Yeah.
That would be a good first stop. And right at the cutting edge of technology, we can actually now do mass spectrometry on the amyloid to further define it.
Or you could just ask a history, have you got lymphoma?
Of course, the simple things.
Save money.
Yeah, you could find out whether they've in fact got myeloma.
Which would be below the chin, but that's okay. You can ask that too.
Yeah. So I think taking a history would be the first good thing to do. I should have thought of that one. Okay, nice straightforward slide. Moving right on to the next one. I'm just going to open all the rooms again so you can join your partner again. Is that okay? Mm-hmm. Okay, we'll do the next slide. I'm going to. That's good. As everybody comes back. How was that?
It's hard to navigate around such a tiny bit in the time.
Yeah, I mean, you will have more time in the exam, but we want to get the most out of today.
Of course, yeah.
Putting you on my gallery view. There we are. Okay, I think we're all back. So one thing that someone asked is, in that slide, it was like a sandwich, wasn't it? There was like 2 bits of collagen and a thin bit in the middle. And they asked what normal part of the eye looks like that. And of course, no normal part of the eye looks like that. But we frequently get conjunctival specimens that look like that because you put them flat into the solution, the formalin, and then they immediately go like that and stick to each other. Mm-hmm. So this is why we often recommend that if you want to make your pathologist a happy person, you just lay the conjunctiva onto a piece of filter paper and it will stick and it will stay in one layer. Otherwise we get unusual sandwiches and curly rolls and other things that can make it a bit difficult.
They roll up like a roller blind, and you can imagine how difficult that is. It looks like a Swiss roll instead of a flat thing. You can also stick them on the back of a suture packet cardboard or glove paper or something like that, but not a paper towel, which will suck the juice out of it and make it awful. So, Anyway.
All right. So who's doing this, Amanda? Me or you? Which?
You did the amyloid. Must be my turn.
Right.
Have you got a picture that you can bring up of the Seaman WHO framework, and then I'll describe it, and then you can go to that.
Yeah. So I think in the little chat thing that not
yes.
chat thing, the we talk that
yeah, you made a little PowerPoint, which I thought was excellent because
I made a little PowerPoint. Should I quickly run through the PowerPoint first?
Yeah, do that, and then we can have a framework to put our slide into. That makes sense.
Okay, here we go. So I'll just open up the Seaman talk that is linked there, and I will share screen. All right. Okay, so here we go. So open with Google Slides.
Are you recording? Oh, yes, good.
I'm recording. Come on, present. Okay, Seaman. Right, here we go. So Pam is now Seaman. And so a new nomenclature for conjunctival pigmented lesions. One of the things that one of the registrars asked me was, if we have PAM without atypia, is it included in the Seaman classification? And I think the answer is yes, and I will show you how here. Right, so conjunctival malignant, melanoma in situ neoplasia. Right, so every proliferation of melanocytes in the conjunctiva gets a Seaman score, a conjunctival melanocytic in situ neoplasia score from 0 to 10. And if this is what we would call PAM without atypia, it would of course get a Seaman score of very low, but they're all scored. And they're scored on 4 things: their horizontal growth, their vertical spread, and their atypia. So fortunately, the Seaman protocol comes with lots and lots of pictures. So normally the melanocytic cells are like 1 every 5. And if you just get basal proliferation of them, you score a 1. Pagetoids are 2, nests are 3, and confluent nests forming this mass is a 4. So that's the radial spread, you know, how many nests there are. Vertical spread is how thick they are. Okay, so this has got confluent nests, but it's also kind of halfway up. So this one would in fact be a confluent nests 4 and a vertical spread halfway up, so probably a 2. And then there's the melanocytic atypia, okay, which we can see down the bottom here. So here we have the nucleus cytoplasm ratio. I can't actually read that on my one. What does it say? Oh, sorry. The nucleus cytoplasm ratio is less than the basal cell. So they're smaller, the nuclei are smaller than basal cells. Then we've got the nucleus is greater than the basal cell nuclei. And then we've got the cytoplasm is greater than the basal cells. And then we've got nucleoli or mitoses are seen, and that's a 3. So now when you're looking at conjunctival intraepithelial lesions, you've got 3 things to talk about: the radial spread, the vertical spread, and the atypia. And here we go. So PAM without atypia would be a Seaman score of 1, because we just have increased basal numbers, but we have 0 for vertical spread, and we have 0 for nucleocytoplasmic increase in size. Yeah. And then mild would score some higher ones, and then of course the melanoma in situ would score more than 5. So the most important thing is to work out what the score is, and then you know essentially how it will behave. So this is something that's been put forward so that we can more easily classify the lesions and more easily predict what they will do. Some people don't like Siemens, and so they've started to talk about low-grade, high-grade melanoma in situ. In other words, clumping together what we would have previously called PAM with moderate and severe atypia and PAM with no and mild atypia. And again, from a behavioral point of view, this makes sense. Okay. So have you all heard of the Ajcc staging? Yeah, okay. So Ajcc staging says that if 75% of the normal conjunctival, that should be an L, not a conjunctiva, epithelial thickness is being replaced by atypical melanocytes, it is melanoma in situ. So if we go back, I'm just having trouble with the back button here. How does that match up with this? In fact, it does match up well with this. Okay, so more than 75%, it fits into this melanoma in situ thing. So that's a key point. I think you can probably remember if it's more than 75% thickness, it's usually associated with marked atypia and will be in that melanoma in situ. Always, when we're thinking about PAM, we have to think about, is it not PAM, semen? Is it a junctional nevus? Okay, so junctional nevi are common in children, but they're rare in adults. So a good rule of thumb is if you see a junctional proliferation in an adult, it's going to be semen. And if you see a junctional proliferation in a child, it's going to be a junctional nevus, unless, of course, there's mitoses and marked atypia. Remember that there's often epithelial invaginations into the underlying lamina propria, which are surrounded by melanocytic cells. This isn't invasion. This is just it being associated with the epithelium as it pops down. And secondly, and third, last of all, the genetics. The BRAF V600E mutation occurs in about 40% of conjunctival melanomas. It's as if I've auto-corrected it to something else. Okay, so of course, maybe it's when it went into Google Slides, the L got read as an exclamation mark. Occurs in 40% of melanomas. So that's my very short presentation about semen. I'm now going to do escape and stop share. So Amanda can do the share.
Okay, and let's talk about this. Boy, it is so hard to find an online slide that demonstrates these melanocytic intraepithelial changes. For speed of rendering, I'm going to leave it onto the small square and just zoom in on my areas. So what I can see on the top surface here, I can see this is conjunctiva. It's got goblet cells, and then I have substantia propria or subepithelial stroma, and then I'm coming into the folded over other side of the conj, and I can see pigment here, and I think this was probably excised because this is a localized pigmented lesion, and that's probably the reason for excision, because I don't see increased pigmentation on this side. It only appears to be in this part of the conj. And I'm going to go, and I can see it's not so bad, then it gets worse, and then it sort of tapers off again. So I'm just getting the landscape of what it looks like. And let's go into here. So I'm going to assess what's happening from, I don't think I can rotate this view, from the radial spread, the vertical spread, and the atypia points of view. So if I'm looking at these cells here, regarding radial spread, I think these it's confluent but individual cells. I can't actually see nests here, a bit squashed. So it's confluent because we should only have 1 in 5, but there's like 1, 2, 3, they're all touching each other. So we've got radial spread, vertical. If these are all melanocytic cells, then they are spreading vertically up at least 50%. Maybe some of them are greater than 50% in height. In this particular area is what I'm looking at. And atypia. are they larger than the adjacent epithelial cell? And I think some of them are larger.
I thought so too.
Yeah, so I see up here in the URL, it's called Pam with mild atypia. I'm at least moderate with this one. So if we grade this out on the Siemens scoring system, I can't have both things at the top. So if we go radial, that would be, it's not one, it's one, isn't it? One.
It's one. Yeah, it's one. It's, I think it's, yeah, it's one. There's no page so separated because one.
And then
plus,
for verticals, I've put it at least 50%. So that's 2, isn't it?
That's 2, yeah.
And then atypia, they are larger than epithelial cells, which
So
is
that's 2, isn't it? So it's scored
it's
a
5.
5.
Yep.
Which would be Pam with severe atypia.
Okay.
I wasn't so sure about it going halfway actually.
Okay.
Because it's so thin, it's hard to tell which is
thin. Yes.
Yeah. But
So,
even if we scored that a 1, it would still be a 4, so it would still be a high grade.
yeah. So moderate Pam or high grade C-min. There's another bit over here, I think.
So John asked, for the exam, should we use Pam or should we use Seaman? And I'm saying that people can show they're really clever by for example, putting Pam with severe atypia or high grade Seaman, and just use the / and do them both.
As long as you state your system, then that's fine. If you just say mild dysplasia, something like that, you have to state the system that you're using.
You do, yeah.
Yeah, both are correct.
Yeah. So we think this scores either a 4 or a 5. Therefore, I'm just going to share my screen.
And I'll stop. And let's go back to that picture.
Yeah. So that would mean that it was here. Because we scored it 1 for vertical. We scored it 1, or I scored it 1, but you scored it 2 for. Sorry, scored it 1 for horizontal. I scored it 1 for vertical, and you scored it 2 for vertical, and we both scored it 2 for atypia because they're bigger than the basal.
The picture slide.
Picture slide.
Yeah, that makes more sense for us. Okay, yeah, so it's got the basal, yep. And it's got the basal, yes. So the melanocytes are touching each other. And then the vertical extension, I thought it was more than 50%, but then it could be just below. So 1, 1, 2, and the size of them, I thought it was equal. So 1, 2, 3, 4. Hold on, 1, 2, 3.
Oh, sorry, I've gone. Sorry.
Here we go. Yep.
Yeah.
You can see how difficult it is, and this is why they have made this grading scale to try and get more reproducibility into the grading.
So if you do get one and just report it like that as radial, vertical, and size, just if you're a kinesthetic learner, radial, vertical, and size, you will get all the points. Okay, it is lunchtime now. We've gone on quite a long time. Should we have half an hour for lunch, team?
And we just should answer a question or two before we get break.
Oh, of course, yes, we've got some questions, haven't we?
Okay, and differentiating from nevus, Chris, just based on child versus adult, a bit more than that. Do you want to address that, Diane?
Yeah, okay. So that was my top tips. So I would be very reluctant to do a junctional nevus in a 60-year-old and a semen in a 5-year-old. So let's I'm not going to forget the clinical this time. Okay, so the macroscopic appearances will be different in a child and an adult with semen and a junctional nevus, in that the junctional nevus will usually be localized and not have a history of increasing in size over years. Microscopically, the junctional nevus often forms discrete nests rather than a lentiginous spread. I've just realized I need to stop share there. So it's the lentiginous spread where they all touch each other. That is the abnormal growth pattern.
What does lentiginous mean?
Lentiginous, and good point. Lentiginous means like a little row of peas along the bottom, all touching each other, whereas the typical junctional nevus is in nests that are discrete from each other. And then there's the atypia. So the atypia will be much more in PAM. Oh God, semen. Now, junctional nevi in children can be a little bit atypical.
Architecture.
Yeah, but the architecture is the important thing. The nests versus the lentiginous spread. Okay, do we still, semen's not used in skin, that's right. Do we use PAM as a clinical term to describe the pigmented lesion, then semen to describe the histology like CIN?
It's a clinical question.
Yeah, I don't know. The difference between ephylis and PAM without atypia, in ephylis, there's no increase in cells. It's just a freckle. There's an increase in pigmentation and there's no increase in the number of melanocytes.
So semen 0. Okay, cool.
All right, I'm going to stop recording and we'll see you again at 12:30.
Yep.
We're not doing the what cyst is this talk now?
We could do it later if we have time. I don't think it's a super important talk.
Okay.
Okay, off we go. I'll stop recording. See you in half an hour.